In 2013, Samantha Banerjee was pregnant with her first child. She was nearing the end of a textbook pregnancy and only had a few more days before she would meet her baby girl.
I was healthy. I was told was textbook the entire time through. I was considered a low-risk pregnancy. And then 2 days before my due date, I walked into the hospital in labor and was told that my daughter no longer had a heartbeat.
Banerjee was blindsided. In her mind, healthy babies didn't just die. But everyone in the hospital said that actually, sometimes they do. Her daughter, Alana, was the victim of a stillbirth, which is the death of a baby in utero between 20 weeks of pregnancy and birth.
The majority of stillbirths take place in the third trimester, close to the time of delivery. And then the other big kind of chunk of them happens right around that early 20 weeks mark is where you see kind of the big, but they can happen anytime in there.
And though Banerjee was told that stillbirths just spontaneously happen, there are actually various causes for the deaths. Sometimes it's an issue with the placenta or umbilical cord, and other times it's an infection. And contrary to popular belief and what medical professionals told Banerjee, Dr. Steve Rad says many stillbirths can be prevented.
A preventable stillbirth is stillbirth in which you can kind of have risk factors or potential markers throughout the pregnancy that put a woman at risk for stillbirth, and those are things you could have monitored and caught early on or did some kind of intervention to prevent.
Rad is a maternal fetal medicine specialist, director of the Los Angeles Maternal Fetal Care Center, and OBGYN to the stars. Some measurable warning signs of stillbirth are if the baby isn't growing well or has a noticeable change in movement. And even though Banerjee didn't know anything about these signals, she had instinctually picked up on some and brought the concerns to her doctor.
I brought it up and they had said, oh, that's normal. She's just running out of room, getting ready for birth. And that is unfortunately a very persistent old wives' tale, which has absolutely no evidence to back it up.
But since the doctor said there was nothing to worry about, she let it go. Every pregnancy is different. There's no universal standard for fetal movement. Each mom has to figure out what normal movement looks like with her own baby. Once that level is found, there shouldn't be a decrease in activity. However, what's not common knowledge, and what Banerjee didn't realize, was that increased or frantic movements are also concerning.
I hadn't had any contractions yet. I thought it was Braxton Hicks contractions. And I laid there on my back, feeling her struggle for the last hour of her life. And I sat there with a smile on my face, thinking, oh, she's getting ready for birth. I'm going to finally get to meet her soon. So the level of just guilt and self-blame is soul shredding.
Like many other parents, Banerjee was told that there would never be a concrete answer to why her daughter died. It wasn't until nearly 6 years later that she happened to sit next to a placental pathologist at a conference. He offered to take a look at the placenta sample the hospital had kept in storage. The slide showed hundreds of blood striations, which revealed that there were complications with Alana's umbilical cord.
The umbilical cord typically has this coiling, which is protective, and it prevents it from getting squished too much or getting tangled too much. And it turns out my daughter had a short, thin, hypocoiled, meaning it was missing much of the protective coiling cord, which made it prone to compression. Her cord over those last couple of weeks was repeatedly getting compressed, and then the pressure would build, and then it would explode out like stepping on a garden hose,
which caused Alana to bleed out into her placenta, making her cause of death feto-maternal hemorrhage.
And this happened over the course of 2 weeks, hundreds of episodes that she fought through and survived until finally a couple days before she was due, she just was not getting the oxygen and nutrients she needed over those last, few critical weeks of the pregnancy. And no one realized it was happening. So when we talk about a preventable stillbirth, my daughter's is a great case because there were many points in there at which we could have intervened if she had been getting more monitoring, things that we would have seen.
But since Banerjee was considered low risk, those extra measures weren't taken. She saw the difference firsthand when she was treated as high risk for her next 2 pregnancies, and therefore had more routine growth scans and detailed ultrasounds.
It was just infuriating that I had to essentially pay for this level of care with my first child's life, because every baby deserves, their best possible chance. And for some reason, we are not giving that to babies in low-risk pregnancies in the United States today. When you are low risk, at the beginning of the pregnancy, you're kind of just assumed that you will continue to be low risk throughout the pregnancy. That unfortunately is not the case. 80% of stillbirth moms do not have any known maternal risk factors at the start of the pregnancy. So that's 4 in 5 of us who go on to lose a child in the second half of pregnancy were considered quote unquote low risk.
It wasn't long before Banerjee discovered she wasn't the only woman affected by this double standard in treatment and the misinformation around stillbirths. While not every death can be prevented, many can, and those children deserve a fighting chance. And so, Banerjee dedicated her life to advocacy and is the executive director of Push for Empowered Pregnancy. It's a coalition of parents who work with medical doctors, researchers, and national organizations to end preventable stillbirth. Rad is on the medical advisory board and uses his own personal practice as an example that treating every pregnancy as if it's high risk is possible and life-saving.
We've found it to be kind of unfair, unethical not to provide the same level of care to low-risk patients because so-called all patients can become high risk.
Rad says one reason that other physicians don't hold these same standards is because the occurrence of stillbirth is still so uncommon that it's not always at the forefront of these doctors' minds.
Stillbirth rate is like 5 to 6 out of 1,000. A provider may only experience a stillbirth in their practice maybe once in their lifetime or a few times in their lifetime. So first of all, the numbers are low. Second of all, we don't always have the resources, unfortunately, due to the healthcare system and the number of providers versus patients and the amount of time you can spend with the patient and how often you can see the patient.
One of the big reasons that we started Push is because, once I finally got those answers, it dawned on me that this was not the failing of any one individual mother. This was not something I did wrong. It was not something any of my friends who had stillbirths, because now I know hundreds of them, did wrong. This is a system level failure. We are not giving parents or their providers the information they need at the right time in order to keep babies safe.
Patient awareness is a huge component, but there also needs to be much more education for medical providers. Banerjee says there's still a lot of misinformation that gets passed around, so even if a patient comes in worried, the provider may still dismiss it, like Banerjee's doctor did to her.
We have just pages and pages of stories from parents who, again, like me, noticed a change, spoke up, and their concerns were dismissed or brushed off. And again, it's not even the provider's fault because this is what they've been taught. We just aren't putting in enough effort to try to catch these deaths. And so as a result, we're losing 65 American babies every single day. That's a school bus or 3 kindergarten classes full of children. And it has sadly been this way for decades.
Thankfully, organizations like Push and Healthy Birthday are fighting back, and change is slowly happening. Congress recently passed the Maternal and Child Health Stillbirth Prevention Act, which allows states to use grant resources for prevention programs and research. We've seen other countries like Australia have great success with reducing their rates of stillbirth by implementing a national plan. Unfortunately, the American College of Obstetrics and Gynecology doesn't have a universal plan of prevention for America's stillbirth problem. Rad says this lack of action is partly due to the difficulties of setting a standard that medical practices of all shapes and sizes can follow.
Sometimes changes to the American College, because they're representing so many different providers across the country in different settings and different communities, it's hard for them to sometimes approve different protocol changes that everyone will be able to achieve because different access to healthcare, for example. And so they have to be careful with what general recommendations they give because not everyone will be able to meet that standard. So I wouldn't say they're doing it on purpose or something. It's just probably very hard to implement in the U.S. healthcare system.
While that may be true, it doesn't change the fact that babies are still dying from preventable stillbirths. Until policy changes and national plans take hold in this country, Banerjee says women need to be educated on the warning signs and empowered to advocate for themselves in a healthcare setting. It starts with becoming familiar with how your baby moves.
What we teach people to do now is to get to know your normal, know what's normal for your baby, know what times of day they're active, know if there's certain stimuli they respond to, be tracking, pay attention to the strength of their movement because they should get stronger and stronger as the pregnancy goes on.
Tracking this movement with an app like Count the Kicks gives you a record to bring to your doctor if you ever feel like something is off.
So much of the problem is that we second guess ourselves as moms, and especially as first-time moms. And so this kind of gives you a tool to give you the confidence to know that, yeah, something changed and I should speak up. You can't always avoid it. Sometimes accidents happen, right? But there are things you can do to lower your risk. And that's what we're not doing today. We're not giving parents or their providers that opportunity to make sure that every possible thing is done. Because we know we'll never be able to prevent every stillbirth, but we feel really strongly that every family who goes this deserves to know that they and their provider did everything possible. Because the most excruciating part of this experience is those what ifs that you are left with afterwards.
You can find more information about Samantha Banerjee, Dr. Steve Rad, and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our executive producer is Amira Zaveri. I'm Elizabeth Westfield.